conservatively. Let us now look at the ligamentous injuries surrounding the knee joint. It is useful to consider the pattern of ligament stresses when, the deformation behaviour of ligaments during loading. And as can be seen on the right, the diagram, under normal load deformation, there is a certain amount of elastic and plastic deformation, but if the ligament is stressed beyond this region of the plastic deformation curve, then there is obviously going to be an injury will occur, and this may be a first, second or third degree tear depending on the load and stress involved. So first of all, let us consider the collateral ligaments of the knee and how these may be injured. The MCL, or medial collateral ligament, is most commonly is the third most frequent injury of the knee. The lateral collateral ligament is less commonly injured. The mechanism involved in the MCL is a valgus type injury, or varus for the lateral collateral ligament, with the knee in close to full extension most commonly, in or close to full extension. The MCL may be injured when the knee is in flexion as well, but commonly hyperextension and rotational stresses will occur as well. Secondary structures which may occur with collateral ligaments are the ITB and the cruciate ligaments, particularly with the ACL and MCL relationship, and avulsion of the head of the fibula for the LCL. The ACL and medial meniscus is known as, for the MCL, is known as O'Donoghue's triad: ACL, MCL and medial meniscus. How are ligament injuries, how do they clinically present? There's often a well-defined mechanism of injury as described previously. There's localised pain over the ligamentous structure. There's a rich innervation, particularly of the superficial fibres of the MCL. There is effusion likely to occur around the MCL, but this is less common with the lateral collateral ligament. In both cases, you will see a loss of extension and also flexion with the medial collateral ligament, and this is due to the mechanics of the ligament during those movements. There will be either varus or valgus instability depending on the ligament involved due to pain inhibition, and there will be positive stress tests for each of the ligaments involved. The management of the ligament injury may well depend on the extent of the injury, but the RICE regime is always appropriate to control the inflammatory component, always seen after trauma. Any electrotherapeutic modalities such as ultrasound and interferential or PME may be appropriate to promote the healing. It is essential to begin an early strengthening and mobilisation program in order to stabilise the knee. Mobility of the ligament relative to adjacent structures is critical as the healing of the ligaments occurs. You don't want the scarring to impair healing. Functional and proprioceptive re-education is also important. If the tear is of a grade 3 and which means a rupture, then a primary or secondary repair is often indicated. So moving on from the collateral ligaments, let us now consider the cruciate ligaments. The cruciate ligaments are important stabilisers of the knee joint, especially when the knee is put into medial rotation. This indicates the ACL rather more than the PCL. ACL tears are far more common than PCL due to the difference in size. Tears of these two ligaments may be partial, complete in adults, or they're in young teenagers, tears may occur, but these will involve an avulsion of the tibial spine. The mechanism of injury for the ACL often includes a hyperextension or forced anterior shear of the tibia relative to the femur. For the PCL, this will be the opposite, such as a dashboard injury where there is a forced posterior shear of the femur relative to the tibia. The varus stress role of the ACL is also important as the lateral ligament of the medial compartment. Cutting manoeuvres are also commonly, especially where there is a force involved, will also affect the cruciate ligaments. And sudden deceleration injuries may occur. How does the cruciate ligament injury patient present? They will often have a history of giving pain and associated giving way, where the knee is relatively uncommon in particular positions. At the time of injury, if there is a trauma, there will be an audible pop or crack, and the patient is usually unable to continue activity due to the swelling, which will occur immediately. And hemarthrosis is seen in 75 to 80% of ACL injuries. Following the injury, the pain may be localised, poorly localised, with a diffuse ache around the knee. There won't be actually any tenderness with the ACL due to the lack of neural supply. And the range of movement will be limited, particularly with a loss of extension and a limitation of range of flexion. On examination, their useful tests for the ACL are indeed the anterior draw and Lachman's test, and for the PCL is the posterior sag seen when the patient is supine with their knees bent. On cross-legged sitting, the gapping of the lateral side will be appropriate or seen or felt, and a positive pivot shift test tests the anterolateral rotatory instability. More functional testing, perhaps into cutting positions or during lunges, may be seen. An MRI is always useful. Instability is a common symptom associated with any ligamentous injury. The types of instability are single plane, where it's just in one, instability only occurs in one plane, such as the sagittal plane anterior posteriorly, the transverse plane in a rotational direction, or the coronary plane in a medial lateral direction. It may, instead of just single plane, there may be dual plane, where there is anterolateral instability, which is indicative of an ACL and LCL or ITB injury, anteromedial, which is ACL and MCL, posterolateral, which is PCL and the posterior capsule, posteromedial, which is indicative of PCL and posterior capsule type problems. The actual mechanical instability can be graded, with 0 being normal and up to grade 3, where there is more than 10 to 15 millimetres of laxity. And perhaps more useful to the clinician is the functional instability can also be graded, with 0 is normal and right up to grade 4, where the various instability occurs with giving way during functional activities such as changing in direction, running straight, changing in direction at walking pace, or giving way when walking forward on level ground. How do we manage instability of the knee? Well, will be immediate reduction of swelling using RICE but potentially aspiration, although aspiration is less used now because of the risk of infection. It will also depend on the severity and presentation, but walking aids may be appropriate, or plaster of the patient to stabilise the knee further may be appropriate. In the intermediate term, function is important with strength, mobility and proprioception, and for the ACL, particularly emphasis on hamstring contraction. In the later stages, restoring function and proprioception becomes more critical, and particularly for the cruciates in terms of sensory feedback. Surgical management of instability around the knee is useful when dealing with being able to allow patients to return to functional activity. There are various different types of surgical intervention which may be appropriate, and these are listed below. Grafting using the patellar tendon, grafting using an artificial graft, an allograft such, from a donor, or ligament augmentation devices. The type of repair or surgical repair chosen is based upon the functional requirements and the possibilities of rejection within the patient. Here's a picture of a patellar tendon graft where the central section of the patellar tendon is grafted to mimic the position of the ACL. There are problems associated with this, and these will be discussed. Post-surgical management of the patellar tendon graft patient are to prepare the patient pre-operatively by using prehab to maximise strength and fitness and help them to learn about the post-op routines. There is a large variation in post-op regimes, and these will be obviously surgeon dependent. But an example of this may be early management will involve protection using bracing and continuous passive motion machines in order to bring back and achieve mobility, teaching of safe transfers from chair to bed, etc. And the early muscle re-education using particularly the hamstrings, and to start in a closed kinetic chain situation with progressive weight bearing from partial to full weight bearing. In the intermediate phase, 6 to 12 weeks, this will then progress on carrying on the closed kinetic chain type activity with squats and leg presses, continuing hamstring activity and calf work, building up with their strength and endurance, and starting to increase their aerobic capacity with perhaps cycling or active water jogging. Proprioception work, in very basic to start off with, and some walking to jogging as long as they have good knee extension. As their rehab progresses, then the intensity of the training increases with the loading, the style of aerobic work into running, progressing from straight lines to simple cutting manoeuvres, as long as their strength and control is appropriate and stability is available. Developing their plyometric strength with cycling and shuttle runs, and avoiding sudden impact work is important. And finally, in the final advanced 24 week plus running drills, more hopping, jumping and plyometric activities are involved, and sports specific work.